All right. Well, good afternoon, everyone, and welcome to another SpeciCare Facebook chat session. I'm Leah Streuber, and I'm here with Dr. Dixon, our founder and chief medical officer. And we also have a panel of physicians joining us this afternoon, and I will introduce them in just a moment. But we do thank you for joining for a very important topic today, and it's caring for cancer patients in the midst of the coronavirus pandemic. And this is just part one of a three-part series, so we hope that you'll join us at least for the next few weeks. You know, our industry has been forced to innovate and change our approach in caring for patients during these uncertain times. And just like our panel of physicians that have joined us today and our hospital affiliates, SpeciCare has had to make adjustments, but we are still collecting live tissue so that we can offer our patients customized cancer treatments and to continue with our mission to give patients new options and more hope. And our company has had the privilege of working with our panel of doctors who join us today, and so we're very excited that they're with us. And the specific topic or focus of today's discussion will be surgical management, and so I'm going to introduce our guest physicians. So Dr. Green specializes in gynecological oncology and is a part of the Northeast Georgia Physicians Group. They have several practices across the Northeast area of Metro Atlanta. And Dr. Clifton Hastings is a cardiothoracic surgeon and chief of medical staff at NGHS, or North Georgia Health System. So we're very excited to have those two gentlemen join us today. And Dr. Dixon, I'll let you take it from here.
Thank you, Leah. And thank you, Andrew and Clifton, for being with us. So both Dr. Hastings and Dr. Green are highly respected members of our North Georgia surgical community, physician community, and good long-term friends. Wanted to start off with a couple of statements. Cancer has new diagnoses in the United States of 1.7 million per year and about 610,000 deaths. In Georgia, the cancer is the second highest killer to cardiovascular disease, with 50,000 new cases every year and about 18,000 deaths. We're dealing with a situation now where SARS-CoV-2 looks like it's displacing cardiovascular disease, and cancer is our #1 killer in Georgia and across the United States. So this is what we're dealing with, a serious problem. Thank you for coming today. Wanted to just first ask you personally, Andrew, start with you. How has the COVID pandemic affected your individual practice? And then Clifton, if you would kick in, and then we'll go from there.
So we've had to do a lot of risk stratification based on diagnoses. There's some cancers you just can't wait on, that you've got to get done in a time frame, whether that time frame be 2, 3 weeks, 4 or 5 weeks. There's other cancers you can push off a little while, but eventually you've got to treat all these. We've had to make some treatment modification plans just because of access in the OR because of the pandemic, trying to minimize risk to patients. Also trying to minimize stress to the hospital system because the hospital's been inundated with so many patients. So now we're about 6 to 8 weeks into this, and I'm personally actually starting to get really busy because all the people I pushed off for 6 weeks are now coming back up, but we can't push them off again. So we're really starting to wind back up almost at full speed, kind of ahead of where the hospital is really ready. But compliments to the hospital, they've really made some accommodations to allow me to take care of this population that it's truly needed care. So it's kind of been an ebb and a flow over a very short amount of time.
Thank you.
Yeah, and I would add, Andrew, middle of March, we suddenly were faced with a decision of what do we do. The American College of Surgeons, CMS, and pretty much all the surgical specialty societies recommended that we stop doing elective surgeries to allow health systems to accumulate the resources needed and to deal with the potential onslaught for large volumes of COVID patients. We have actually in our hospital seen significant number of patients. We actually did stop doing elective surgeries, and many of those surgeries were planned surgical procedures for in my specialty, lung cancer. What I have done largely is in certainly stage 2 and stage 3 cancers, we are moving ahead with adjuvant therapy with the idea that we can go ahead and proceed with surgery, hopefully in the next 2 to 3 months after they receive their chemotherapy and or radiation. Some patients who had isolated stage 1 disease, we had a long discussion with the patients, and they elected to go ahead with radiation initially with the idea in 6 months that we more than likely would at least have the conversation as do we resect. And I think from a staging perspective, that's going to be key. We continue to do PET scans and other diagnostic studies as needed so that we can appropriately stage these patients. But the reality is, as Andrew pointed out, cancer is not something that waits. And so now that we have developed the resources and developed the plans that we needed to help us do more than one thing at once, we are isolating areas of the hospital so that we can go ahead and do a lot of these life-threatening and life-saving procedures. And I know Andrew has been doing more of those. I've been very fortunate in that we've been able to, working with our oncologist as well as the radiation oncologist, at least delay some of the surgery. But I do think that over the next few weeks, the unique thing about thoracic surgery is COVID-19 affects the lungs significantly. You lose probably 20 to 30% of your respiratory capacity in the recovery phase of that. Well, if you take 25 to 30% of a patient's lung out with lung cancer surgery, and then they get something like COVID on top of that, that puts a unique life-threatening perspective on that. So we have a much better handle on it now. I think we're going to be moving forward over the next few weeks as the capacity and the resources of the health system allow.
I know that you both have been involved with the surgical team, anesthesia team, perhaps some other physicians in the hospital, with making the decisions about how to ramp back up the elective cancer surgery or semi-elective cancer surgery. Would you comment on that in relation, for example, to the AJC article just this morning that was talking about the coronavirus throughout North Georgia, and how you can respond? You're making decisions now that you can make in real time, and how you respond to changing environment. Why don't you go first, Clifton?
So when this pandemic and the need to cancel things started, I actually slated about 8 surgeons and anesthesiologists to help me within a week to start planning on a reentry plan. While we were dealing, Andrew was very instrumental in helping us design and implement a lot of the policies that we did to implement the response to COVID. I had a separate group of people working on that reentry, and Dr. Schultz, Kip Schultz, neurosurgeon, was the chair of that committee and done a lot of great work. Within a month, they had a plan ready to go. So we have the framework and such ready to go. When and how we implement that is going to depend on the impact on the community. The AJC article was a nice summary of what's been going on the past 5 weeks. But the reality is, on the ground in the hospital itself, we're starting to see either some plateauing or maybe even a slight decrease. And our hope is that's going to continue. But more importantly, we've been able to now know and understand what our needs for the COVID patients are. We've created over 75% increase in our ICU beds, and they're actually in a section of the hospital away from the area where we do our surgeries and such. So we feel that now that we've had time to respond and ramp up our abilities, we think that there is the capacity to take care of other disease processes. And we've been doing emergency surgeries all along. But as Andrew was talking about earlier, you can't wait forever on these cancer diagnoses, and it's life-threatening and even lifestyle limiting issues. So we are confident that we can move forward and do more than one thing at once. We're doing this in a safe way to make sure that the patients are kept in an area that's away from COVID. The last thing anybody wants to do is to leave their home from quarantine and end up getting a disease such as COVID. So we're doing all sorts of things that we can to minimize that. So it's really understanding what the problem is much better now, as well as having a plan in place and the resources in place to deal with both problems.
I think one of the keys too is now we're actually able to test all the patients coming in for COVID, because when this started 6 weeks ago, we could barely test the patients coming in the hospital with symptoms. And now every patient that gets admitted to the hospital is getting a COVID test, but specifically the OR patients, everybody's getting tested for any procedure so that we know their COVID status to the best of our ability coming in. And that's really allowed us to save a lot of PPE for the frontline staff. It really needs it to take care of the COVID patients. So we're doing some things like that. We're testing, doing temperature screens on people who are working at the hospital, and really have now got our arms around the ability to take care of these people in a safe way. Whereas the first 4 weeks of this, we were spending time scrambling, trying to figure out how we were going to do that. And this committee really implemented a great flexible plan that we can ebb and flow as the needs of the hospital and the needs of the community go. So if we see a second spike, we can pull back to a lower level of surgical care as far as numbers and kinds of cases. If it lightens back up, we can continue to progress to ramp right back up. So, it's really been a lot of people working together, but I think that ability now to test all the patients coming in has really made something more effective and allow us to really aggressively start taking care of some of these diseases.
I know the American College of Surgeons has put out some guidelines, and we're working from them, but y'all have any feedback about how we're doing things here in North Georgia compared to other hospitals ramping up surgery around the nation? Can you give me a little feedback about that?
Well, I would say each health system, depending on where you are, is going to ramp up based on their local needs. When I look at our neighbors in Savannah, 2 weeks ago, they had 7 patients in their entire health system that were COVID positive. At that time, we had over 300, so that were either suspected or positive. So they're in a unique position. So there are going to be places throughout the state and throughout the country that are going to be able to move along more quickly. Unfortunately, I think the biology of this disease process is such that over the next year, we're going to be dealing with many surges and many hotspots throughout the country. So it may be in September, Savannah has a surge or something. So I think having the ability, as Andrew said, to ramp up and to also pull back as needed, keeping a close eye. We have a dashboard that tells us how much PPE, how many beds are available, critical kits available, ventilators available. So I know twice a day what that capacity is and what that capability is. And so we're able to, almost in a real-time fashion, adjust what we're doing to deal with those issues. So, and I suspect other health systems have that capability as well. So that is actually that transparency has helped us a great deal in planning and moving ahead.
Andrew, do you feel like y'all can switch directions quickly enough if you need to, if you see changes?
I think we've proven we can. We went from full speed to 0 to ramping back up to kind of critical cases to over a 2-week span, moving back, even doing some tier 1 cases to 2 weeks after that, planning to go full speed in the operating room on June 1st. All of that predicated by what are the COVID numbers and things doing. And the best thing I can say, the ability to be able to do that, is because all of the surgical community sees the needs of the community as a whole and is looking at the community as a whole and not their individual practices. Everybody's seen in the paper about how medical practices are getting hammered by this like other businesses. And our colleagues have really done a good job of doing what's right for the community, oftentimes at their own detriment for their practices. And I think that just is a testament to the community we work in and the people who work in our hospital.
I have one more question, then Leah, I think you've got a question, but the issue about COVID patients we've got medical staff that's taking care of the COVID patients, and then we've got, as we increase the surgical volumes back again, we've got nurses and medical staff taking care of those patients. Is there anything being done to try to segregate those two aspects of medical care?
Yes, okay, go ahead, Clifton. I'll let you take it.
So I would tell you that we had about 70 ICU beds for adults in the system in the middle of March. We now have almost 140. So we've been able to greatly expand that. We put them in a medical surge area over in the South Patient Tower and created negative pressure rooms for all of that. So we have been able to move those patients with COVID to those areas where they are protected better by the negative pressure environment, but also protecting the staff a lot better. In doing so, that's freed up some other areas. So we've had to move things around, move people around. But the focus now is from a surgical perspective, we test patients before they come in so we know they're negative. They enter a part of the hospital where COVID patients don't really interact at all. They go to the peri-op area, the operating room, and PACU area in a separate area away from any potential COVID patients. And then if they have to stay in the hospital or in a unit that does not accept any COVID patients. So anything we can do to minimize the risk to the patients is already in place. I do believe the state's going to bring a mobile unit that's going to put another 24 negative pressure beds out in the area outside the hospital. So that will actually expand our area for COVID patients and open up other areas in the hospital. So as we expand and continue to grow, I think we're going to have the capacity to do that. If that changes, we can always dial back. But the other thing is we've been doing screening for the employees since the beginning of this time. We've been doing temperature checks and there's policies, procedures, and things in place to allow to allow the employees to get help if they need it. You can get tested anytime you need it. And then the other thing is antibody testing, which is still an unknown. It's available, but we're not quite sure what to do with it yet. But Mayo Clinic's working with us on that. So hopefully we're going to have that piece of information as well. So I feel confident. As I had a good friend of mine's mother who's 88 have a hypertensive emergency, and I said, go to the ER. They're segregating patients. You'll be fine. And she came in and got care without any problem.
All right. Well, my question for both of you is, how are you personally handling the COVID risk, and what are you doing to keep you and your family safe?
Go ahead, Andrew.
I've got a high school senior who has had the end of her year modified, to say the least. So I have been spending most of my time counseling my children. And, honestly, they've done a great job and they understand, but we have been following the CDC guidelines and trying to do everything we can to follow those guidelines, because my wife works in the healthcare industry as well. So the short answer is I've been trying to be an example of what you're supposed to do, much to the frustration of my children sometime. But we've been self-isolating and cooking a lot at home and stuff like that.
And I would agree with Andrew. I can tell you my world changed on March 14th when suddenly we decided to cancel surgery. And as a surgeon, that's what you do. But fortunately, there were a lot of other issues that a chief of staff had to deal with. And with the good help of Andrew and a lot of other great medical staff members, we've been able to create policies, procedures, and operationalize the things that we needed to do to address this. I will tell you, the past week has been almost a breath of fresh air. I feel like we've done the work that we need to do to deal with COVID. We're prepared to go forward. And now I feel like I can actually start becoming a doctor again. So I'm looking forward to, as we move forward, to being able to do more surgeries, take care of patients. And as you implied, taking care of ourselves, we're doctors in general, surgeons specifically, do not do that very well. So that's actually been a focus. My wife has been telling me I need to do certain things, and I've started to listen. And I know Andrew has as well. We've had this conversation offline. So we're starting to listen to those around us who notice what we need to do. So we're hard-headed, but occasionally we do listen.
Yeah.
I'm going to turn it back over to Leah in just a second, but I want to thank y'all for coming and talking with us today. Thank you for your continued excellent care of our mutual patients. Thanks to all the nurses out there and the other hospital personnel. Cindy reminded us today that we needed to thank Marianne and Val, that are 6 Northwest nurses working with us as well. And so thank you.
It is Nurses Week, so we have been thanking them all over the place. And again, nurses, the respiratory therapists, the physical therapists, everybody on the front line, they have really been doing their job. And Ken, I want to thank you and the work that SpeciCare is doing, because we are going to be changing the face of cancer care in the future with all the things that we've been doing. So it's critical that we continue along those lines as well.
Thank you.
Wonderful. Well, I think that that's a great way to wrap up today's session. So thank you again, Dr. Green and Dr. Hastings, for joining us for this Facebook chat. We look forward to a secondary topic on this broad topic of caring for cancer patients during the coronavirus pandemic next week. So thank you again, and I hope that everyone has a safe and pleasant afternoon.